A very big hello to all my dear students. How are you all? Welcome to your favorite channel, You and I with Dr. Ruchi Rai. We are giving a little bit of break to the A to Z series because we are today here to discuss some rapid fire revision for Fmge students. I got a lot of requests from the Fmge students, so I thought let me try to revise with you all. Now, before I start, let me tell you one thing, that it has to be very, see the name itself, the heading itself gives you the message, and that's a rapid fire discussion. So all of you who have studied nicely will enjoy the session, and if you're listening to for the first time, please don't, this is not for you, right? Because it will be a very quick session. Purpose of discussion is more about, okay, please study this topic, study this topic. It is more about giving you an idea that you cannot miss these topics for your preparation. Do you get it? And details will not be possible in this session, right? I'll be covering few questions around it. All these discussions will be image based and based on your PYQs, right? Okay. Let's start with the rapid fire revision here. Okay, so you see a slide here. What is this slide all about? Just 1 minute. Yes, so what is this slide all about? We see the different types of cataract. We know the main senile cataract can be cortical and nuclear. So let us label very quickly and understand. Initially, it's an immature cataract with radial spokes. What do you call this? We call it cuneiform cataract, isn't it? Okay. This cuneiform cataract slowly is going to lead to finally a mature. This one is your mature cataract. And when there is a hypermature stage for cortical, this is what is, you can see the nucleus is sinking in the liquefied cortex. We all know we call it Morgagnian, right? There's an exam question here, guys. What is the most common complication of Morgagnian cataract? What will you answer? Most common complication of Morgagnian is phacolytic glaucoma. Okay, so it is phacolytic glaucoma, right? Okay, and what about this one? Hope these pictures are clear to you. What are these? This is what is your posterior subcapsular. A lot of questions on PSC, guys. क्या पढ़ना है आपको? This is which lenticular opacity diminishes the vision most? Maximum diminution of vision. It is your PSC, posterior subcapsular cataract. Second question. It is the most common complicated cataract. You know what is complicated cataract? When cataract is occurring after any anterior posterior segment disease. Third, it is the most common radiational cataract, right? And what else is asked in the exam? That if you talk about toxic cataract, let us revise it here. It is busulfan, steroids and chloroquine which will lead to PSC. BSC causes PSC. Busulfan, steroids and chloroquine will lead to PSC, right? Okay, next slide. We come to the, oh, no, wait. I think I missed something. Yes, we missed this one. What is this? This is your nuclear cataract, isn't it? This one is the nuclear. If you look here, these are the clear area and this is the part which is being affected, right? Initially, it starts from here. So, we call it nuclear cataract. Okay? So, nuclear cataract, what very important question that they ask? Number one, there will be difficulty in day vision, isn't it? So, nuclear cataract, there will be day vision is affected. Day vision will be less because during the day pupil is constricted and this is a central opacity is affected more, right? In nuclear. Second, of course, I have taught so many times in my previous videos that I think you should be thorough with this, and that is your second sight of old age. It has been a repeated question, don't forget. This is a feature of nuclear sclerosis or nuclear cataract. And let me remind you what it was, a very quick thing here. Any nuclear sclerosis increases the refractive index and therefore the overall power of the eye is increasing. So this is what is called index myopia. Myopia has more power, you know this, and therefore we need lesser number on specs. So there is improvement of presbyopic glasses. Pata hai na? Got it? All of you? So this is what is your presbyopic glasses. So this is what is second sight of old age. Right. We come to the next slide is showing you what? Let's have a look here. This is what is anterior surface is conical. This is your anterior lenticonus, isn't it? anterior lenticonus. This is characterized by, when you see this patient in retroillumination on slit lamp, what is this known as? Very important exam question, oil globule reflex. Isn't it? This is oil globule reflex. Okay, next question. This one, anterior lenticonus. One more question, more common in males. Another question, in which syndrome at your level we'll learn only one, Alport syndrome. What is Alport? Alport syndrome is familial hemorrhagic nephritis. It is familial hemorrhagic nephritis. Right? Okay, so this is what is familial hemorrhagic nephritis, right? Hemorrhagic nephritis. Okay, these are the questions, and then you come to the next figure, which is showing you the posterior lenticonus. And posterior lenticonus, जो यहाँ पे, it is the posterior surface. Can you see? This is the corneal section. If this is the corneal section, naturally this is anterior and this is posterior. It is the posterior which is conical this time. And the only question that you have to know, this posterior lenticonus is a feature of, what will you answer? Loeys syndrome. What is Loeys syndrome? It is oculocerebrorenal syndrome. Right. Okay, we come to the next slide. When you have learnt oil globule, this one is, all the oils are covered here now. This is your oil droplet cataract. Where do you get oil droplet cataract? Was also a very recent question in Fmge. You will answer galactosemia, right? So galactosemia. Another question on galactosemia is that the cataracts may be reversible cataract. If any cataract is reversible, it is in galactosemia. Otherwise, cataracts are not reversible. And we know this, right? Okay? Yeah. Okay. So this is oil droplet cataract, another question. And this is also a question, oil droplet reflex. Now all the oils are covered. What is oil droplet reflex? It is seen in patients of keratoconus. What is keratoconus? Conical protrusion of cornea. At the base of the cone, you see this. How do we see it? Of course, globule reflex through slit lamp, oil droplet cataract by slit lamp, but this one is by distant direct ophthalmoscopy, right? You know what is a direct ophthalmoscope and indirect? I'll just discuss that. So distant direct means direct you take very close to the eye. When you do it, see it at a distance, we call it distant direct. Another question, at what distance do you do distant direct? I hope you remember, 25 centimeters. Okay, we come to the next slide here. What is this? This is sunflower cataract. We know sunflower cataract is mainly a feature of calcosis. What is calcosis? Copper alloy in eye, right? Copper in eye is calcosis or copper alloy in eye, whatever you say. So pure copper actually causes phthisis bulbi. What is phthisis bulbi? Blind shrunk eye. Achha, okay, let's not complicate it. Your level, just learn copper in eye is your, when you say copper in eye calcosis, it occurs due to either foreign body or due to Wilson's disease. Isn't it? Another thing that we will learn here is Kayser-Fleischer ring is a feature of this condition, right? What is Kayser-Fleischer? I hope you remember. I think that we will see the slide there. It is copper deposition in the Descemet's membrane, seen as a golden ring near the limbus. This is also Q. This is also Q. We come to the next slide. What is this? Complicated cataract. I just explained you what is complicated cataract. Exam question. What are you seeing? What are these different colors? This is what is called polychromatic luster. So this is actually a pathognomic feature of complicated cataract is polychromatic luster. Opacities are breadcrumb in appearance. And what else have we learned? Breadcrumb opacities. Okay, what else we have learned? Another thing that we have learned is about very, very important, most common type of complicated, abhi bhi padha tha, PSC, that is posterior subcapsular. Come to the next slide. What do you see here? Again, looks like complicated or polychromatic luster. No, these are needle-like opacities seen in myotonic dystrophy. We are talking about Christmas tree cataract. We will remember this. And what is this? This is the snowflake or snowstorm cataract, which is seen in diabetes mellitus. Okay. Exam question, why do you get cataract in diabetes? You will say it's a sorbitol accumulation on the lens, in the lens. We remember this? All the metabolic pathways are mainly saturated. Sorbitol is formed. This is hyperosmotic. It imbibes water and causes cataract. Okay. So these are the two very important questions here. Right? Okay. We come to the next one. What is this? Okay, what is heading I can give if I'm putting Christmas tree cataract and diabetic cataract together? Both are pre-senile cataract. Don't forget, these are pre-senile cataract. You know, before 50 years of age, it can happen. Diabetic, and another pre-senile is this one, atopic dermatitis. In atopic dermatitis, what type of cataract you get? As you can see, it is shielding the pupil. We call it shield cataract. So this is another exam question. These are the three pre-senile: diabetic myotonic dystrophy, atopic dermatitis, and diabetes that you have to know. And of course, because we were talking about shield, I also added this slide. What is this? This is shield ulcer. It is not a cataract, it's a shield ulcer. ये shield कहाँ मिलता है ulcer? This shield ulcer is a feature of vernal keratoconjunctivitis. Right? Okay, we come to the next slide. What are we seeing? I can see these are all riders here, isn't it? These radial opacities, and it's involving one lamella. So we are talking about lamellar cataract where you see these riders. That is first question. ठीक है? और क्या याद करोगे? Exam question है, it occurs due to vitamin D. Which vitamin deficiency? It is vitamin D deficiency. ठीक है? Another thing is, most common congenital which is causing diminution of vision, it is lamellar. And most common congenital overall is blue dot. Another important point, it is mainly also seen in Down syndrome. Blue dot cataract can be seen in Down syndrome. Right. We come to the next type of cataract. What heading I can give to this slide? Can you think with me? This slide I will give the heading congenital cataract. This slide I gave the heading, of course, these are pre-senile cataract, right? What about this one? This is your blunt trauma. What you see in the blunt trauma? What are we seeing here is rosette shaped cataract. Hai na? Rosette shaped cataract starts from what part of the lens? They ask you, you will answer posterior cortex. Starts from posterior cortex. Okay. Another important feature is this one. Iris pigments are imprinted on the anterior capsule of lens. This is important. This is the anterior capsule of lens as asked. And what is this known as? Vosseous ring. Okay. Another feature of blunt trauma. They will ask you this. KF ring, Vosseous ring. This is important. What are you going to give this slide a heading? This slide is nothing but post-operative complications of cataract surgery. Most dangerous, endophthalmitis, right? So this is endophthalmitis is the most dangerous complication, and this one is your most common long-term complication is your posterior capsular opacification. This is called after cataract, also called after cataract, right? Yes. What is the treatment? NDR posterior capsulotomy. यह पूछा जाता है. You have to remember this. NDR posterior capsulotomy. Okay. What are the questions on endophthalmitis? What is endophthalmitis? It is mainly inflammation of the recent definition says intraocular fluid. समझो. Inner coat of the eyeball along with vitreous, right? So when you say this, next question is that which is the most common etiological agent. For early onset, I hope you remember, it is staph epidermidis, and for late onset, it is what is in late onset? Propionibacterium acne. Late onset, Propionibacterium acne. Okay, got it? Okay, we come to the next slide. What is this slide showing? Okay, these are the different stages and types of cataract surgery. So here what we are seeing is capsulotomy, which is by capsulorhexis. Please, you have to know this. Sometimes they can ask you the step, what is hydrodelineation and what is hydrodissection. I hope you know a dissection means injecting water under the capsule. Anyway, what is this? This is your phacoemulsification. The question asked in phaco is, what is the length of incision? You will answer 2.75. पौने 3 से सवा 3. ऐसे याद करो 2.75 mm to 3.2 mm. This is your important exam question. Everybody knows phacoemulsification is when we use ultrasonic energy is used to break the lens, right? Okay, what is the frequency of the ultrasonic probe? You should answer 40 kilohertz. I don't think this has been asked in your exam, but this is important. That is your incision length. Another thing, this is also important slide in asking the question, what are you looking at? Which surgery is this? Femto laser assisted cataract extraction, where with the femto laser we are doing the capsulotomy here and we are doing lens fragmentation in this slide, we are doing the lens fragmentation. Okay, so this is femto laser assisted cataract extraction. You have to know all this. We come to the next. Sorry, this is repeated. Okay, so these were the important questions on this chapter. We come to glaucoma. What is the normal cup disc ratio? You should know what is cupping is damage of the optic nerve, thinning of the neuroretinal rim, and increasing of this pale area, which is called cup area. So what is the normal CD ratio, cup disc ratio? It is less than equal to 0.3. When it increases, we call it cupping. When it is significant and we should be worried. Now this is again another important fact that we generally start working about significant when it's more than 0.6. Learn 0.6, not 0.7, learn 0.6. Okay. But yes, if the question is what is the normal CD ratio, this has to be answered like this. Okay, what do you see here? What are the other features that you can see in the fundus finding in a glaucoma patient? I hope you know what is glaucoma. It is damage of the optic nerve, right? Okay, anyway, so when these nerve is damaged, these openings of lamina cribosa from where the nerve is exiting out, that is visible. This is what is called laminar dot sign. What else I can see here? I can see nasal shifting of vessels. So increase in CD ratio, thinning of neuroretinal rim. This is the thinning of the rim. I can see where thin rim. And of course, cupping in glaucoma is always vertical. Don't forget that. Okay, so nasal shifting of vessels. I've explained you why. I can't do that in detail at present here, but please explore it. So this is your nasal, these are the signs of fundus examination, right? Then we have what is the best choice of seeing these fundus changes. The patient is being sitting in the slit lamp, examiner is using both his eyes, and now he is using this lens. Why? Because slit lamp you can see only up to vitreous and 1/3. If you have to go behind, you have to use this lens. This is lens most commonly used is plus 90D. Okay, and what is this investigation? Slit lamp by microscopy. And this is actually the investigation of choice for seeing the fundus changes of retina. Okay, investigation of choice. What is the next thing that this is asked in your exam generally? Of course, is your acute congestive glaucoma and angle closure glaucoma, isn't it? So please revise your angle closure glaucoma in stages. Coming to acute congestive glaucoma, it is also called acute primary angle closure. What happens in this? There is a redness, pain, photophobia, of course. Pressures are very high, up to 60 millimeters of mercury. And with such a high, what is the normal IOP? They can ask you this. Normal IOP, I hope you know, is 10 to 21 millimeters of mercury. So this is the patient with vertically, this is important please, this is vertically oval mid-dilated pupil. You have to revise all this, right? With the cornea is cloudy because of the corneal edema, there is redness. Question is, how do you treat it? How do we treat it? Of course, pilocarpine will constrict the pupil and open the angle, but it will not react to any drug because such a high pressure iris is ischemic. So, सबसे पहले क्या करोगे? Go for IV acetazolamide or you can go for mannitol. Okay, IV mannitol. Then if this is done, then you follow by pilocarpine eye drops. Just remember this. This is asked in the exam. This is in case of acute congestive stage of angle closure glaucoma. If they ask you what is the choice of treatment of angle closure, it is peripheral iodotony by NDR. That is the definitive treatment. Okay. Of course, what you see here is the congenital glaucoma with Buff-Thalmos. The question they ask you here is what is the treatment of choice of and of course you can see corneal edema. So this is the child of congenital glaucoma. What is the treatment of choice has been your exam question. Answer is this one. This is goniotomy, cutting through the angle. So you see the goniotome going through one angle and then coming under the anterior chamber, going to other angle, and there's a sweep action we put to scrape the Barkhan's membrane from the angle. ये होता है goniotomy. और क्या क्वेश्चन आएगा? They can ask you about what is Vogue stria कहाँ मिलता है? Vogue, V for V is vertical. It is seen in keratoconus because the break in the Descemet's membrane here is parallel to the steep axis. But when you talk about congenital glaucoma, now the break in Descemet's membrane is almost like this, and horizontal like this. Can you see this? So this is your Hab stria, this is your Vogue stria, right? So they can ask you this, keratoconus. Okay, we come to the next slide. What is this you see? If I want to give a heading to this slide, it is tonometers. Now first one is your Schiot's tonometer. When you say Schiot's tonometer, they can ask you that which is more reliable, Schiot's or Goldman Of course, most reliable is Goldman, and it is also the gold standard. Okay, just remember this. Right, so this is your Goldman tonometer. You have to revise how it works, how we are seeing two Mayas as a semicircle. We try to join the two inner margins of the two Mayas like this. Right? Okay, another thing is, what is this? This is the applanation. Another applanation is this one. This is rebound because we are fixing it on the forehead, and you can see it in your, you can measure the tension in your own eyes. So rebound tonometer exam question is used for self-measurement. Will answer self-measurement. What is this? This is a pulsar. What is a pulsar? I don't use any instrument to flatten or aplanate the cornea, but I am using a puff of air. So if they ask you which is a non-contact tonometer, it is pulsar, right? Okay, then we talk about what is this? This is tonopen. Tonopen, one question. It is the choice of instrument or tonometer in infants, small children and infants. This is the choice. And second, what you have to know, second thing very important that we have to know is that tonopen can also be used in scarred and irregular cornea, right? Okay. Next question is, as you can see here, the tonometer is on the lids. This is your transpalpebral tonometer. This is called diaton tonometer. Another transpalpebral is when you're doing it digitally, isn't it? Digital. Transpalpebrally हुआ ना, lid के ऊपर से करते हो, right? Okay, then we talk about, you have to revise anti-glaucoma drugs and its mechanism of action and its side effects. Okay, they ask you. So this is what is difference in the iris color heterochromia iridis. So the eye has been, which drug is responsible for the difference of this? It is mainly latanoprost. Latanoprost, in which eye it is given? This one, right? Because it causes pigmentation in the iris by stimulating the melanin production. We come to the next one. This is hypertrichosis. Again, hypertrichosis is a side effect of PG analogs. And next, what is this? Look here. This is your lid retraction. Alpha agonists can cause lid retraction. Mainly, we are talking about apraclonidine. Okay, apraclonidine. And what about brimonidine? Please don't forget, it can cause drowsiness. Number 1. It should be avoided in children as it can lead to CNS depression. Number 2. Number 3, you have to know brimonidine can be given in pregnancy. We come to another side effect. As you can see, these are conjunctival deposits mainly by adrenaline, that is epinephrine. Okay, so these are the conjunctival deposits. You can see here. Okay, we come to this one. What is this? This is your vortex keratopathy. What do you also call it? Cornea verticillata. Please read it in detail. What are the drugs like chloroquine, amiodarone, tamoxifen? So which anti-glaucoma drug is causing vortex? The newer one. Which newer one? Netasodil. Okay, you will remember this, Netasodil. Okay, yes, so we were talking about direct. This is your direct ophthalmoscopy, as you can see here. And what do you see? What are the questions asked? Magnification of a direct ophthalmoscope 15 times. Okay, that's a good one. So you can see the central retina. Okay, next question. Third question, what is the type of image formed here is virtual and erect. So at Fmge level, I don't think anything more is asked, but see, one more interesting thing which was asked in your exam was that if you look at this figure, is this picture, so the right eye of the patient is being examined by right eye of the examiner. So please remember, right same hota hai eye. They have asked you this as well. Okay, समझ आया? और distant direct ophthalmoscopy क्या बताई थी? Ophthalmoscopy, understand? We are mainly examining the retina. So distant direct क्या बताई थी? When the same instrument is seen at a distance. Now I can't see the retina. What I am seeing is the media of the eye. Okay, we come to the next one. What is this investigation? This is what is indirect ophthalmoscopy. This is how you do it. Okay, a headband with a light source. This is the lens. Which lens is most commonly used? It is plus 20D. Okay, another important question in indirect ophthalmoscopy, what we are seeing? Periphery of the retina. Magnification is how much? Around into 3 or into 5. And of course, the image is real and inverted. So these are the important points we will learn for this indirect ophthalmoscopy, right? These are all important questions. See, I've made cues, right? Okay, so I think in this session, we'll take up to this much, and I will add a few more sessions. So to cover up the Fmge revisions, right? So thank you so much. Hope you enjoyed it. Stay blessed and keep studying very, very hard. Right? Thank you. Keep smiling.